Neurology Quiz number 97. Describe the etiology, clinical features, pathogenesis and treatment of hemifacial spasm or HFS. HFS is characterized by involuntary, episodic, unilateral contractions of the muscles innervated by the facial nerve. Clinical features: the prevalence is 7 to 14 per 100,000 and it is more common in women. Most cases are sporadic, though rarely familial cases may occur. The disorder usually begins in adulthood with an average age of onset of 45 to 50 years. It is characterized by twitching of the muscles innervated by the facial nerve, most commonly unilateral. Typically, twitching first affects the periorbital muscles or the orbicularis oculi, but spreads to other ipsilateral facial muscles over a period of months to years. The spasms are synchronous in the affected muscles, and they can be clonic or tonic, and often a paroxysm of clonic movements culminates in a sustained tonic contraction. The spasms occur spontaneously, but they can be provoked or exacerbated by facial movements or by anxiety, stress, or fatigue. Weakness of the affected muscles may be noted. This figure illustrates the occurrence of involuntary movements which begin in the orbicularis oculi muscle around the eye and then can spread to the eyebrow and the face. In approximately 5% of patients, the opposite side of the face becomes affected. The condition generally does not cause significant physical disability. However, it often causes social embarrassment, resulting in severe psychosocial issues for the patient. In some patients, recurrent contractions of the orbicularis oculi muscle can interfere with vision. This is a video of hemifacial spasm. It shows unilateral twitching of muscles innervated by the facial nerve. As noted, it is often most prominent around the eye in the orbicularis oculi muscle, but can also affect the facial muscles. This is a figure which shows the facial muscles that can be involved in hemifacial spasm. Etiology and pathogenesis. The most common etiology of HFS is compression of the facial nerve at the root exit zone by an ectatic or aberrant artery. Vessels commonly implicated are the posterior inferior cerebellar artery, the anterior inferior cerebellar artery, and the vertebral artery. At the root exit zone, focal demyelination occurs, allowing ephaptic transmission or lateral spread of excitation to adjacent nerve fibers. This causes ectopic transmission of impulses with resulting twitching of the facial muscles. An alternative theory is that irritation of the facial nerve at the root exit zone may induce changes within the facial nerve nucleus and cause excessive firing of the nucleus. Intracranial space-occupying lesions are found in approximately 5% of patients, usually in the cerebellopontine angle. These include epidermoid tumors, neurofibromas, meningiomas, and astrocytomas. Tumors of the parotid gland can also cause hemifacial spasm. In some patients, HFS may be a sequelae of Bell's palsy. This represents a synkinesis secondary to severe axonal injury and misdirected regeneration of the axons. Rare causes include brainstem lesions such as the demyelinating plaques of MS. Diagnosis. This is usually made from the history and the examination. MRI brain with and without contrast is performed to rule out underlying compressive lesions or other pathology that can be associated with HFS. MRA is not performed routinely unless microvascular decompression of the facial nerve is being considered. This figure shows a grading scale for the severity of hemifacial spasm. Treatment: oral medications. Traditionally, patients with HFS were treated with anticonvulsants like carbamazepine, benzodiazepines such as clonazepam, baclofen, and anticholinergics. However, these were often not associated with benefit and caused significant side effects. Botulinum toxin. The introduction of botulinum toxin injections revolutionized treatment of the disorder. Botulinum toxin is injected into the orbicularis oculi and other involved facial nerve innervated muscles. It is the treatment of choice and usually the only treatment required. It is associated with clinically meaningful improvement in almost 100% of patients, and side effects are mild and transient. The injections must be repeated every 3 to 4 months. Follow-up of chronically treated patients shows that injections retain efficacy for 15 years or more. The figure on the left shows the technique for injecting botulinum toxin into the orbicularis oculi muscle, while the figure on the right shows the areas where the botulinum toxin is injected. About 2 to 4 units are injected at each site. Surgery. Intracranial microvascular decompression of the facial nerve is successful in the majority of patients. However, it can be associated with significant complications such as facial nerve injury and hearing loss. For these reasons, botulinum toxin is the treatment of choice and surgery is rarely performed. It can be considered as an alternative in patients who are resistant to botulinum toxin treatment. This figure shows an abnormal vascular loop on the left pressing on the facial nerve and on the right during microvascular decompression. A sponge of Teflon or gel foam is placed between the vascular loop and the facial nerve.